طيب يا جماعة without further delay السلام عليكم جميعا ورمضان كريم وتقبل الله الطاعات. أنا محمد أنور غندور من الدفعة السابعة. إن شاء الله الليلة حكون معاكم في إن شاء الله 1 hour from talking about kidney issues related to COVID-19 and I hope this initiative initiated by the Academic Office of National Report University Medical Grad will take the lead, and inshallah we'll continue to present more lectures not only about the COVID, but inshallah will be for our junior medical students, and inshallah we'll keep it as a regular presentations. I will start my presentation with no disclosure. The first slide that I wanted to start with is saying staying at home every day keeps corona away. And I hope everyone will spread the word to everyone, especially to our people in Sudan. Staying at home is the most crucial step nowadays. And as they are saying, prevention is better than cure. So I hope everyone will listen and keep staying at home. Today's objectives, I will start my talking about how to accurately assess the workup of acute kidney injury. Secondly, we'll talk about the AKI in COVID-19 patients. And as we will know later on, almost 30% of our patients who got COVID, they will develop AKI. We'll touch base also about end-stage renal disease in COVID-19 patients. We'll have a few talk about chronic kidney disease and hypertension. And we'll also speak briefly about COVID-19 in kidney transplant patients. All right. We'll start with a case presentation that I dealt with. I have a 57-year-old female with past medical history significant of chronic kidney disease, stage 3, heart failure with preserved ejection fraction, hypertension, obstructive sleep apnea, and type 2 diabetes, who presented to our hospital with shortness of breath requiring oxygen therapy. Unfortunately, the patient continued to be in respiratory distress despite being escalated to non-breather mask. So therefore, the patient intubated and connected to mechanical ventilator. Subsequently, the patient transferred to the medical ICU for further medical management. And at this point, we have been consulted as nephrology for acute kidney failure. Patient past medical history, as we mentioned, was significant of hypertension, obstructive sleep apnea, and diabetes. Past surgical history was significant of left hip replacement. Family history was positive for diabetes and asthma. Patient denied any smoking, tobacco, alcohol use, illicit or recreational drug use. And her home medication included amlodipine and hydralazine and metoprolol for hypertension, aspirin, and gabapentin. The patient is not non-drug allergic. So the initial workup, when she got to the hospital, it showed that the PUN at admission was 17, creatinine of 1.3. However, the creatinine was trending up and increased up to 4.8 with PUN of 46. Her baseline creatinine was 1.2. And by baseline creatinine, I mean this is the previous creatinine prior to admission that the patient is known of. Patient was also oliguuric, meaning the urine output is less than 400 cc over the 24 hours. The urinalysis was only positive for 2 crosses of protein. Electrolytes was within normal limit. The ABG was consistent with respiratory acidosis, and the COVID-19 workup, we call it like CBK was 106, LDH was high at 363, and ferritin was high as well. The fraction excretion of sodium was less than 1, which goes with a picture of pre-renal acute kidney injury. Renal ultrasound was not remarkable, and the kidney size was normal. So the next step, the patient had started in what we call continuous renal replacement therapy. It's a kind of dialysis, but again with a slow rate, and it continues for more than 24 hours because the patient is hemodynamic unstable, so patient will not tolerate intermittent hemodialysis. So we continued the CRRT for 72 hours. Patient hemodynamic status improved, and then we switched to intermittent hemodialysis. Following the CRRT, the BUN and creatinine dropped to 2. As you remember, the creatinine was 4.8 when we had been consulted. However, the patient was still anuric, meaning she will require dialysis frequently till 3 months to decide if this patient is going to be a chronic kidney disease, dialysis dependent, or the kidney functions will recover. The next step, I will start talking about what is acute kidney injury. So acute kidney injury, acute means onset, which means hours to days of decreasing in the glomerular filtration rate. Some authors, they call it acute renal failure. The incidence of the AKI is estimated to be 5% in all hospitalized patients. However, this incidence increased by doubled by 50%, like increased to 50% in ICU patients, which makes sense because the patient will be hemodynamic unstable, they have decreased tissue perfusion, and they are more susceptible to have AKI. Part of the initial history should be determining the baseline creatinine. And let me take 1 minute to explain what's baseline creatinine, especially to our people in Sudan, because we don't do a regular follow-up with primary care doctor or kidney doctor. So the term baseline creatinine, it reflects the patient's pre-morbid kidney functions that should be known. And this value is really important because we compare the subsequent creatinine values to what we got during admission. And I will tell you in the next slide what is the importance of the baseline creatinine. The mortality actually is really high in like 75 to 90% in patients who develop sepsis and associated with AKI. And it's less with patients without sepsis, although it's still high to around 35 or to 45%. We have different criteria to diagnose AKI. We have what we call the acute kidney injury network criteria. We have other criteria like the kidney disease improving global outcomes and the RIFLE criteria. However, they all share the general picture of increasing creatinine by 1.5 to 2 from the baseline, or increasing by 0.3 milligram per deciliter, and this is for stage 1. For stage 2, it's defined by increasing creatinine by 2 to 3 times, or decrease the urine output to less than 0.5 ml per kg for 24 hours. While for stage 3, defined by the creatinine increased by more than 3 times, or creatinine by more than 0.5 if the baseline is more than 4. On the other hand, the urine output should be less than 0.3 ml per kg per hour for 24 hours, or patient is anuric, i.e. urine output is less than 100 cc per hour over the last 12 hours. Let's take an example. If the patient baseline creatinine 0.5 and the patient came to the hospital with creatinine of 1, both numbers are within normal range, but still this patient is AKI because the creatinine increased by 0.5 from the baseline within 1 day from admission. Also, if the AKI consistent and did not recover till 3 months, then this meets the definition of chronic kidney disease. And the patient will have chronic kidney disease and needs to be on follow-up, whether the patient on dialysis or not, but this patient is having chronic kidney disease and is at more risk to have developed end-stage renal disease. This slide is really important. A patient creatinine going from 1 to 2 is much more concerning than going from 2 to 4. Why? If you notice in this graph, if the creatinine rose from 1 to 2, look at the GFR. It will drop from 50 to 25, meaning it will drop by more than 50% in the GFR. On the other hand, if the creatinine increased from 2 to 4, look at the GFR, it will drop from 25 to 12.5, meaning it will only drop by 12.5. It's not like if the creatinine increased from 1 to 2, where the GFR will drop by 25. So it's not about the high number. If the patient baseline creatinine of 4 and then got admitted of 4.5, it's not as risky as the patient of baseline creatinine of 1 and then the creatinine on admission was 2. The more harm will be with the patient who came with a creatinine of 1, which rose or increased to 2. How can we approach a patient with AKI? As we learned from our medical school, we have 3 types of causes of AKI, whether it's before the kidney or pre-renal, or the kidney itself, or obstructive or post-renal. The problem with the pre-renal, it could be from any reason that leads to decreased tissue perfusion, i.e. dehydration. Also, patients with heart failure, they have high effective circulating volume, but the heart is not able to pump enough blood to the tissues. So the patient will have less tissue perfusion and will be susceptible to AKI. Also, patients with liver failure, they have systemic vasodilatation, then the tissue perfusion to the kidneys will be decreased. They will have more trend to have AKI, and both of them, they called cardiorenal and hepatorenal respectively. Also, it could be renal disease. The renal could be from ATN, acute tubular necrosis. It could be acute interstitial nephritis, and this is likely from drugs. It could be glomerular disease, or it could be from vascular or vasculitis. Post-obstructive, any reason that causes obstruction, like post-renal, that can lead to AKI. So as I mentioned, the causes are pre-renal, intrinsic or renal disease, and we have the glomerular disease like glomerulonephritis. We have a lot of types of glomerulonephritis. It could be due to diabetes, focal segmental glomerulonephrosis. It could be from any cause, membranous glomerulonephritis, or it could be tubular injury by direct toxin to the kidney, or it could be interstitial nephritis from medications mainly, or any kind of vasculitis that can result with causing AKI. All right, so now we knew the causes of AKI. How can we diagnose acute renal failure? History is very important to know and decide what is the cause of this kidney injury. Is it pre-renal, renal, or post-renal? Because it's very important that will be have different approach in the management. Physical exam will tell us as well to decide which category as well. Urinalysis, which is the window to the kidney. Also, ultrasound, which will tell us if, for instance, if this patient is having obstruction, ultrasound will tell us. If this patient is having chronic kidney disease, ultrasound will tell us, okay, this patient is having shrunken kidney, loss of corticomedullary differentiation that goes with chronic kidney disease other than AKI. Other tests, if we didn't know the cause of this kidney injury, then we'll go and proceed, for example, to renal biopsy, which could help to give us the final diagnosis of what's going on to the kidney. So as I mentioned, history is very important to know whether this is acute or chronic, to know the baseline creatinine. If the ultrasound showed, we have a previous ultrasound showing this patient is having chronic kidney disease. Also, in some cases, even with chronic kidney disease, ultrasound will not be shrunken, as diabetes, HIV nephropathy, adult polycystic kidney disease, and amyloid kidney. All of those, the kidney size will be even bigger than 12. If this patient is having obstruction, a physical exam will tell us by palpation of the bladder, it will be distended. Again, in the physical exam as well, you need to assess the volume status of this patient. If this patient is dehydrated, like the pulse will, like patient will be tachycardic. The JVB as well, if the patient is having heart failure, JVB will be raised. Central venous pressure, if the patient is dehydrated, it will be less than 4. Posterior hypertension, it will give us a clue about if this patient is having hypotension or no. Daily weights for heart failure patients. Disproportionate increase in urea to creatinine ratio. Remember, if the patient is dehydrated, they will have more PUN retention or less filtration of the urea, then their PUN will be even higher than the creatinine. Urinary sodium concentration. which is very important in the fraction excretion of sodium, and we will talk about this in a few. Fluid challenge: if the patient is dehydrated and you give this patient a bolus of 1 liter of IV fluid, then he might respond. If the patient is having intrinsic kidney disease and he's anuric, it will be unwise to give this patient like IV fluid because the patient is already anuric and he will not respond. Does this evidence of renal parenchymal disease? Histophysical exam, they will tell, and the urine sediment. You take a urine sample, you spin it, and you look under the microscope, and it will give you some answers. If this patient is having acute tuberous necrosis, then you might see a granular cast. Also, if there's any major vascular occlusion, that could lead to acute kidney injury. Also, this is one of the causes we need to look off. The urine test, we're anticipating that if the patient is having pre-renal AKI, the urine osmolarity will be high because the kidney will try to concentrate the IV fluid, water retention, so the urine osmolarity will be high. Also, the urine sodium will be less than 20 milliequivalent, and the fraction excretion of sodium will be less than 1. On the other way around, in the intrinsic and the post-renal, it's almost variable, and the fraction excretion of sodium will be more than 2. When we spin the urine, we might see some muddy brown granular cast or white blood cell cast. This is a very neat picture of the muddy brown granular cast of indicating ATN. When we spin the urine, we can look at it and find it. So this is the overall approach to a patient with AKI. Now, let's back to our COVID and see the AKI in COVID-19 patients. So the incidence of in one published article in March from China, the AKI has an incidence of almost 30% in patients who are critically ill in they diagnosed with COVID, meaning in each 3 patients, 1 of them will have AKI that's requiring advanced treatment. How would we evaluate AKI patients in COVID? Do we have any difference? The only difference will be emphasis should be placed on optimization of the volume status. Why is that? So most of the time, the critical ill patients who have diagnosed with COVID, they come with respiratory distress, adult respiratory distress. Patient will be intubated on mechanical ventilator most of the time or on high breathing treatment, meaning they have a problem with lung will be full of fluid. So giving the patient IV fluid will be unwise. So judicious hydration will be advised for those patients. And most of the time, we lean toward not give aggressive IV fluid to those patients. Other than that, the evaluation of other AKI etiologies should be undertaken in manner similar to other critical ill patients with AKI. And the manual urine sediment examination can be performed, could be performed. Actually, some people, they say it's a contraindication to do like urine sediment, but no, you can do it without any problem. Kidney and bladder ultrasound may not be able to be performed due to exposure or concerns, so we don't rely on it a lot. How about the management of AKI in COVID-19 patients? I will divide it into 2. AKI patients who require dialysis and AKI patients who does not require dialysis. If the indications of renal replacement therapy for AKI remains the same, meaning if the patient is having uremic symptoms, persistent hyperkalemia, or fluid overload that did not respond to medical treatment, or like diuresis, then here this is the time where you will interfere and start patient on renal replacement therapy. And renal replacement therapy, it might include the intermittent hemodialysis. This is the regular hemodialysis that we know of, and we see it in Sudan. Or we can have the continuous renal replacement therapy. The dialyzed suspected or confirmed patient, if possible, should be in their isolation room. So the continuous renal replacement therapy or prolonged intermittent renal replacement therapy, i.e. the PERT, or the other name is SLED, is preferred over intermittent hemodialysis. What does that mean in English? So as I told you, if the patient is hemodynamically stable, then we do the intermittent hemodialysis. This is the regular dialysis. That's what we do in Sudan. Continuous renal replacement therapy, this is a different modality of hemodialysis that we do it for patients who are hemodynamically unstable. So we do it slowly over 1 to 2 days, or it could be continued longer. It depends on the patient status. We took less fluid. The blood flow is even less than the intermittent hemodialysis. So we will not interfere with the hemodynamic status of the patients, especially those patients will be on pressors. And they will not tolerate removing fluids as compared to the intermittent hemodialysis. I believe in Sudan we have, in Khartoum particularly, we have less than 5 intermittent hemodialysis CRRT machines, but I'm not updated whether we have more or not, but that's what I know of. This is a picture of the intermittent hemodialysis machine, CRRT machine. Sometimes here in our hospital, we place the CRRT machine outside the room to minimize the exposure. We use extended tubing. This is good for preventing or minimizing exposure. But the cons of this is it increasing the risk of tube disconnection. Also, it will decrease the sensitivity of pressure alarms to detect tubing disconnection. So the tube could be disconnected, and nurse that take care of this patient will not be aware. And most importantly, and this is the most important thing, is increasing the risk of clotting due to longer tubing lengths. As we know, as Muhammad Faisal mentioned in his previous lecture, the COVID-19 patients, they are at high risk of having clotting. We don't have a clear reason why is that, but one of the theories that we have the L-type and H-type ARDS in COVID-19. The H-type is consistent with shunting, and it found that it increasing the risk of clotting. Therefore, those patients are prone to having clotting other than the normal patients. And by placing this tube, it will increase the risk of clotting, which is already increased. So we usually recommend against doing the extended tubing. All right. So what if the patient is, even with the CRRT machine, is hemodynamically unstable and he cannot tolerate it? Or you have deficiency of the CRRT machines and you need to do something. Let's give an example. If in Sudan, in one hospital, I have 1 CRRT machine and I have 3 patients, and those 3 patients are critically ill, they require intermittent renal replacement therapy, but I only have 1 CRRT machine. The answer will be, we have a modality called high volume hemofiltration. What is the high volume hemofiltration? Basically, it's the same CRRT machine, but I will increase the rate of the fluid removal or the blood flow to a higher doses, and for a limited time, in particular 8 hours. So the advantage of this will be I can dialyze more patients within 24 hours. Instead of dialyzing 1 patient in 24 hours, I can have 8 hours for each patient. This is the first advantage. The other advantage is it will help to correct the acidosis, metabolic acidosis in particular, more rapid or faster than the CRRT itself. In one study about the high volume hemofiltration in adults with a burn who develop septic shock and acute kidney injury, it found that the high volume hemofiltration is held effective in reversing the shock and improving organ function with septic shock and AKI. And I have introduced this modality in our hospital, and actually it worked really well in our patients, and they recovered even better with the regular CRT machine. So it's something to consider, something we can do it in Sudan. It's the same CRT machine, but especially with limited number of CRT machines and increasing critical ill patients, we can use this modality for sure. But it needs a well-trained people. All right, how about anticoagulation? As I just briefly mentioned, circuit thrombosis during renal replacement therapy occur more frequently in patients with COVID-19. So in absence of contraindications, patients with COVID-19 should receive anticoagulation during renal replacement therapy. Usually they give low molecular weight heparin, but if the patient is having acute kidney injury, the unfractionated heparin can be used as well. All right, the role of AKI with peritoneal dialysis when hemodialysis or CRT machines are scarce. So some of the theorists, they say, why not, if we don't have CRT machine and if we don't have enough intermittent hemodialysis, how about peritoneal dialysis? The answer is no. Why? Peritoneal dialysis can increase the intra-abdominal pressure that interferes with the respiratory mechanics. And that will lead to worsening of the respiratory failure, especially patients who are intubated and on mechanical ventilator. However, only one case reported, and it stated that patient with peritoneal dialysis can benefit from, like, peritoneal dialysis can be used in a patient with mechanical ventilator, especially those are on prone position. And by prone position, I mean it's one of the modalities that we use if the patient is critically ill on having ARDS or mechanical ventilator, he is not improving. One of the modalities is to flip the patient over. It needs a certain expert people to do it. Sometimes it shows some benefit, but most of the time it indicates that this patient is really critically ill and he's increasing the risk of mortality. All right, now we spoke about the patients who have AKI requiring dialysis. How about the patient with AKI that does not require dialysis? Patient needs to be managed, and we have to minimize exposure as possible. Physical examination, ultrasound evaluation should be coordinated with the primary and consulting team. The main reason here is try to minimize exposure to our healthcare personnel, and on the other hand, take care of the patient. So as much low as possible, we have to minimize exposure. The differences in the management of AKI among patients with COVID-19 patient is limited use of an intravascular intravenous fluid. And again, I will say it again, those patients are already having ARDS, adult respiratory distress syndrome. They are already have a fluid challenge. So giving them fluid will worsen their condition, no matter the status of the kidney. So please be wise and do not be generous in giving IV fluid in patients who are having ARDS. Now let's talk about end-stage renal disease patients. Patients with end-stage renal disease, they have more risk of having COVID-19 because of the old. Most of them they be in older age, and they have multiple comorbidities, diabetes, hypertension, and other comorbidities. We have different modalities of dialysis for outpatients in end-stage renal disease. We have the regular in-center hemodialysis. We have home hemodialysis. We don't have it in Sudan. Although this modality, it has been started on 1960s, and it's really, it showed increased survival and better quality of life compared to those who use other modalities. The problem with it, I think the people, they don't like to prefer to use it because they think it needs a well-educated people to know how to use this machine. But the answer is no, you will be trained well to use it. So hopefully, I hope soon in Sudan they can use this home hemodialysis modality. And the third modality is the peritoneal dialysis. In Sudan, in particular in Police Hospital, we have one of the biggest centers of peritoneal dialysis in Africa, and they are doing really a good job about the peritoneal dialysis. Patients who are receive hemodialysis as an outpatient, meaning like we see in Sudan, in Shahida Selma, in Sudan, and Police Hospital, we have regular dialysis unit. They get dialysis 2 to 3, in Sudan, I believe 2 times per week, even less than 3 times. This limits their ability to observe physical isolation for infection control. Very important, and because we have a lot of patients, they got dialyzed at the same time in the same room, is early recognition and isolation of individuals with respiratory symptoms. And we should have a very flexible policy, even if the medical staff, the nursing who are taking care of the dialysis patient, if they develop any symptoms, please send them home. They should be isolated. We should identify the symptoms prior to coming to the unit and instruct the patients, please call us back if you have any symptoms so we can arrange and dialyze the patient in a certain place, like a separate place in the corner in the dialysis unit, if we don't have dialysis unit. Or we can use the hepatitis B room if certain hospitals or certain places they use separate room for the hepatitis B patients. Patients who receive home or hemodialysis patients should have the regular follow-up visit performed via telemedicine. In Sudan, we have the peritoneal dialysis, and they do frequent visits to the patients at home to make sure that they have the adequate setup for the peritoneal dialysis. Nowadays, it's advised just to give the patients a call and please update me about your status. You don't have to go and increase the risk of exposure to those patients. As I mentioned, we should minimize the home visits and provide at least 2 weeks of dialysis supplies and sufficient medications. What if those patients got admitted? Again, they should be localized on a floor or intensive care unit when possible. Why? Because we need to dialyze them separately. Sometimes we try to not to see the patients frequently, only 1 time per day, and then the rest of the day we can communicate through the phone. Switching to continuous renal replacement therapy if hemodynamic unstable. Here I have a trick. Most of those patients who have end-stage renal disease, they have AV graft or AV fistula. They use it for dialysis. The problem with CRRT, we prefer to use a tunneled or non-tunneled catheter. This is like the temporary dialysis catheter we use for urgent dialysis. And we are advised against use the arteriovenous or fistula or graft because it shouldn't be on CRRT unless no other access is possible, because increasing the risk of dislodging the needle and causing bleeding or injury to the AV fistula or AV graft. So whenever you have an end-stage patient who require dialysis through the CRRT, please place a temporary dialysis catheter to be used and avoid using the AV graft or AV fistula. One more step about the chronic kidney disease and hypertension patients who develop COVID. A nationwide analysis done in China and involved almost 1,600 patients. They found that the prevalence of CKD is more frequent among patients with severe disease, and hypertension per se is a common among those who had severe COVID-19. Okay, next will be my talk about, we will hear it a lot. Should we, if the patient is having ACE inhibitor or ARB, angiotensin receptor blocker, should we stop it or not? The people say, okay, patient receiving like the membrane-bound angiotensin enzyme 2 functions as a receptor for the SARS-CoV, and because the ACE inhibitor and the ARBs may increase the expression of those angiotensin converting enzyme 2, there is some speculation that those patients with COVID who are receiving these agents may increase the risk for severe disease. And the answer is, do not stop it. There is no clear evidence that to support the association with ACE or ARB with more severe disease in patients who have COVID. The other thing is, those patients who are using ACE or ARB, probably they have advanced heart or kidney disease. If you stop those agents, they can exacerbate comorbid cardiovascular kidney disease and increase the mortality. And less contraindicated, do not stop the renin-angiotensin system inhibitors. And I touch base on that. There is no evidence that stopping ACE inhibitor or ARB. And also there is no evidence to support the association between the renin-angiotensin system inhibitor and the more severe disease. Next step is dialysis access planning in advanced kidney disease. Patients who have stage 4, the GFR is less than 30, or CKD stage 5, GFR less than 15, are prepared for dialysis access placement and should undergo this procedure as planned. Some hospitals, and we are one of them, we don't do elective surgery nowadays in the COVID time. But the dialysis access is crucial. So if any patient requires dialysis access, then please, it's a must. You have to do it. So placement of AV fistula or AV graft for hemodialysis and peritoneal dialysis catheter for peritoneal dialysis are essential procedures and shouldn't be deferred. How about the kidney transplant recipient? We don't, unfortunately, in Sudan, we don't have a lot of kidney transplant center. Most of those people are on immunosuppressant, myforic acid, they are on tacrolimus, and they are on steroids. What we do in our program is we try to minimize the dose of those immunosuppressant, particularly the tacrolimus, because it has a risk of increasing vasoconstriction and worsening the AKI if the patient develops AKI. So usually we minimize we decrease the dose, or we hold the medications during the active disease. One more thing is, what is the situation in Sudan? Well, unfortunately, we don't have a lot of data about the number of dialysis units, the number of machines for dialysis that needs to be used for urgent hemodialysis. I don't have any clue about the CRRT machines. As far as I know, we have almost around 5 intermittent hemodialysis machines, CRRT machines to be used in Sudan. But don't quote me on this. I don't have exact number. What I found through my search is the incidence of AKI is almost 5.7. This is close to the incidence of AKI globally, which is 5. While in Sudan, the estimated incidence of new cases of end stage is almost 70 to 140 per million inhabitants per year, which is, if we have 40 millions, 40 times, like if we took the average of 100, this is more than 4,000 new cases of end stage every year. This is a very high number. We don't have a lot of dialysis units to occupy. They don't get enough dialysis weekly, which is 3 times per week. And the problem will be, and we don't have enough, like most of them, they will be having permanent, like the tunnel dialysis catheter. We don't have the ability to create or to establish AV graft, AV fistula for all patients. And I'm not talking about Khartoum, I'm talking about the rest of the states in Sudan. So it's really frustrating. The CRRT machines, as I mentioned, we don't have a lot of CRRT machines. If and only if we have CRRT machine in one hospital, we have a lot of patients who require who are hemodynamic unstable and require dialysis, I advise to use the high volume hemofiltration, which is with the same CRRT machine. This is a CRRT machine. We can use it like for 3 patients in 24 hours. Each patient will receive 8 hours, and then we'll repeat the cycle the other day unless the patient improved and he doesn't require more vasopressors or is hemodynamically stable, then we can take him off the CRRT. The other way around is we can use the sled, which is a slow dialysis. It is with the same intermittent hemodialysis machine, but we use it for continuous 6 to 18 hours. It needs expert training, and I think this could be one of the alternatives where we can use the sled as an alternative. It's the same dialysis machine, so it's one of the things that we can use. Or if we don't have any option at all, then with the intermittent hemodialysis machine, the regular dialysis machine, if the patient on pressors, then the only way will be increasing the pressure doses and try to avoid fluid removal as much as possible, because this is a pros and cons. You want to remove toxins, you want to remove fluid, but on the other hand, the patient is hemodynamic unstable and he doesn't have enough support. So that's really challenging. So those will be the 3 options. If the CRRT is available, that would be great. If not, or if we have limited CRRT, a lot of patients switch to high volume hemofiltration. SLED would be an option, or intermittent hemodialysis with increasing the doses of vasopressors and decrease the fluid removal. And by this, I think I will conclude my talk about the AKI in COVID. And the final thing is Liberty is not a statue anymore. She's alive with flesh and blood. We are always carrying this يعني شعارات الثورة عندنا وسوداننا إن شاء الله الواحد يأمل إنه يعم الخير والنماء في السودان وإن شاء الله حنبنيه. I will stop here, and if anyone has any question, I'm more than happy to answer.